Good morning, everyone. We welcome you all to yet another CPD webinar series organized by the Society for Health Research and Innovation. Today, topic would be principles of drug prescribing and deprescribing in older adults. Before moving on to the lecture, let me walk you through some of the housekeeping rules again. The webinar link will be available from 9 a.m. to 9:50 a.m. to join in, and no late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points, and these CPD points are strictly adhered to the NCCPD guidelines. This is to improve and maintain the standards of the CPD program conducted by the Society for Health Research and Innovation. We thank you for your strict adherence of these CPD regulations and your kind compliance. Regarding asking questions, there is a question time at the end of the webinar. If you have any question, you can type it into the chat function, and we will be asking the question at the end of each lecture. And if you have any specific questions about this lecture or anything else, you can email us on to office313@gmail.com. Today, our topic is principles of drug prescribing and deprescribing in older adults. This is a very timely topic with the context of rapidly increasing geriatric population worldwide and in Sri Lanka. And today, our speaker is Dr. Sithira Senevirathne. Dr. Sithira Senevirathne is a board-certified consultant geriatrician at the National Hospital of Sri Lanka. He holds an impressive array of qualifications, including MBBS from the Faculty of Medicine, Colombo, and the MD in Geriatric Medicine. He completed his foreign training at Oxford, United Kingdom, gained international recognition by earning membership of Royal College of Physicians, and further strengthened his credentials with specialty certification examination of MRCP in geriatric medicine. Dr. Senevirathne is a profiled academic with many scientific publications at numerous local and international forums, showcasing his work to diverse audiences and contributing to the advancement in geriatric medicine on a global scale. His areas of interests include orthogeriatrics and geriatric palliative care. Dr. Sithira Senevirathne, it is my great pleasure to invite you to discuss the principles of prescriptions and deprescription in older adults. Over to you, sir.
Thank you very much for that kind introduction. So let me share the slides with you. So thanks again. And as Sudhari said, so it's a very timely topic to discuss about principles of drug prescribing and deprescribing in older adults because of this. So world population is rapidly aging, and Sri Lanka has the highest proportion of older adults in South Asia. And if you give the figures, so we are reaching 20% of our total population being more than 60 by the next year, and it will be like 25% by 2040. So you'll be seeing a lot of older patients in your clinics, in your GP practice, and in your inpatient wards. So it's, I think, important to know about geriatric. Every doctor, I think, should be able to handle the geriatric problems and have some knowledge about how to prescribe medications for geriatric patients. So problems in old age can be very vast, but we always discuss about these 5 things. So these are called geriatric giants. And the geriatric giants are instability, immobility, incontinence, impaired cognition, and the iatrogenic problems. So the instability, as you know, presents with poles, and immobility means the problems with mobility, and incontinence is like fecal and urine incontinence. And delirium, dementia, you might have encountered a lot of older patients with confusion. And the last one is the one we are going to discuss today, the iatrogenic problems. So when you talk about iatrogenic problems, we have this term called polypharmacy, right? So the term polypharmacy means, as you can see, poly means multiple, pharmacy means drugs. So usage of multiple medications. By definition, they say it's 5 or more medications concurrently, including over-the-counter prescription drugs, right? And so if someone is taking 5 or more medications, it has its implications. So that's why we recognize it as a separate entity called polypharmacy. All right. And as you know, the older patients are very susceptible to uh, changes in medications. So that's due to multiple reasons. So let me give you some understanding about the pharmacokinetic changes in physiology of older people. So if you can remember, so we have like 4 things when we discuss about pharmacokinetics: absorption, distribution, metabolism, and excretion or elimination. All right. So as we old, so there are changes in these pharmacokinetic mechanisms. For example, the absorption is mainly reduced due to reduced GI mortality and due to reduced planktonic blood flow and reduction of mucosal surface area and so on. And when it comes to distribution, so when you grow old, your lean body mass goes down. So if somebody asks you what happens to your body fat percentage when you grow old, you might think because of the shrinkage, the fat percentage goes down. But it's not the case. So because your muscle mass goes down faster, your percentage of your body fat goes up. So the fat soluble medications, they tend to accumulate in your body more. So for example, if you think about benzodiazepines, right? So their half-life will be longer in older people. So the effects like sedation will be much more pronounced. And so there are some other changes like reduction of serum albumin and increased serum glycoproteins. And when it comes to metabolism, because of the aging organs, hepatic blood flow is going down, liver mass is going down. So the phase 1 and phase 2 metabolisms are not happening as in a younger person. And when it comes to excretion, because of the reduction in nephron size, renal blood flow, and GFR, the renal elimination will be reduced. So drugs tend to accumulate in your body more. Right. So I am planning to discuss a case scenario with you and then try to describe the principles of drug prescribing and deprescribing through this story. Okay. Right. So this is about Mrs. Pereira. She is an 80-year-old female who has been recently discharged from the hospital following treatment for urinary tract infection associated with delirium. Delirium means a transient condition where the patient is get confused. So you might have encountered similar patients in your practice. And now following discharge, she was seen in the geriatric clinic with her daughter. So it seems like this person is getting recurrent admission of over last 3 months. In fact, this is a second admission. Now, when you talk to the patient, she reports feeling giddy and her legs are giving away. That's what she complains of. So she doesn't feel stable. So she is having a tendency to fall. As a result, now she has developed a fear of falling. All right. And although she denies falls, so her daughter has found her on the floor 2 days ago. And she also reports feeling sleepy all day and she has constipation. She has difficulty in holding the bladder. Right? We call it urgency. And she lives with her husband, who is 82 years old. It's a kind of typical situation in most of the patients. So they live there with their spouse, who is also older. And the daughter stays close by, and so she visits, and she found the mother has left uneaten meals, and she also doubts mother is taking medications properly. Okay, so there's a problem about compliance. Her past medical history, when you look at the past medical history, so not uncommon to have multiple comorbidities, because as you know now, when the patient is getting older, they accumulate medical problems over time. Okay, so she has hypertension, diabetes, bilateral knee joint osteoarthritis, and she had some problems with anxiety, and she has urge incontinence. So those are the past medical problems. And when you examine her, now her supine blood pressure is 138. You might think it's uh, all right, but when she stands, her blood pressure drops further. Okay, so she has postural hypertension, and she feels giddy. Very common, not uncommon, but sometimes we tend to miss postural hypertension because we don't have much time to check in our busy clinics. And her, when you look at her recent reports, her HbA1c was 5.8%. And we did something called abbreviated mental test score. It's a very kind of quick score to see someone's cognition, which is 6 out of 10, means it's impaired. Okay. And when you do a FRAX score in this patient, she had a high major osteoporotic fracture risk and hip fracture risk, which are 14% and 6%. Right. Now, looking at the history and examination, can you think about her main problems? I'll give you a few seconds to think about it, then we'll list out the problems. So she has falls. So even though she can't remember the falls, so there's objective evidence the daughter has found her on the floor. So she had a fall, even though she can't recall. That indicates she has some memory problem, isn't it? So she was recently treated for acute delirium, but still now, even after discharge, she can't remember things and she seems confused. So we are not quite sure whether she has a long-standing cognitive impairment or whether it's still resolving delirium. Too early to say, but she has some memory impairment. She has postural hypertension, so which you saw earlier, and she complains of poor balance, and she has developed fear of falling, and she has urinary urgency, and she has constipation, she has sleepiness, poor compliance. I think the HbA1c is too strictly controlled, so it's 5.8%. So we'll discuss this later when we discuss principles of prescribing. And so when somebody is frail, you have to have a lenient blood sugar control target. Now HbA1c 5.8% means too strict control. Right. So these are her drug list. So as you can remember, she has high blood pressure, diabetes, and osteoarthritis, urinary urgency, and anxiety. All right. So she's on medications to treat these comorbidities. So these type of drug charts are not uncommon. Actually, most of the patients are having longer drug charts. Now, I previously told polypharmacy. There's an entity called polypharmacy where, like, if someone is taking 5 or more medications, we call it polypharmacy. Now, this patient has 3 antihypertensives, namely amlodipine, tenoflomethiazide, which is a diuretic, and ramipril. And she's on 2 hypoglycemic agents, metformin and gliclazide, to control her blood sugar, right? And she's on Panadine for pain due to knee joint osteoarthritis. She's on amitriptyline 25 to help with her sleep and anxiety. And she's on solifenacine to help with her bladder, which is an anticholinergic drug, which we give to relax the bladder when you have incontinence. And she's on lactulose for constipation. And she's on aspirin because somebody put her on aspirin because she has diabetes and high blood pressure, thought she's having high risk of cardiovascular events. So she's on 10 drugs. So do you think this prescription is appropriate or inappropriate? It's very difficult to say actually, just by looking at the drug chart. So it needs a thorough evaluation. But she is on 10 medications. So if somebody is on 10 medications from a geriatric syndrome point of view, we call it extreme polypharmacy. So irrespective of whether they are appropriate or not appropriate, when you are taking 10 medications, you have to face some problems. For example, they have drug-drug interactions, right? And they interact with your other diseases, all right? And there's a problem with compliance. So most of the patients find it difficult to handle complex prescription regimes. So they increase false risks, right? And there are further implications. So we'll discuss as we go on. All right. So now we discussed about the problem list. now we are looking at the drug list, right? So can some of these symptoms be due to medications? That's our question. Okay. All right. Now, when you prescribe in younger patients, sometimes you might not see many adverse effects. But when you prescribe an older person, because they are very frail, a feature of frailty is now they are susceptible to medication changes. All right. And they are susceptible to medication side effects. So we'll discuss one by one. Right. Now, this lady complains of postural hypertension. Right. And this is her drug chart. So can you think about drugs which can cause postural hypertension? If you could put in the this text, the chat, that will be great. What are the drugs that can cause postural hypertension? Great, ramipril, amlodipine, excellent. Happy to see people are interacting. Yes, excellent. All right, good. So yeah, yeah, excellent answers. Benfluoresin, excellent. So drugs like amlodipine, benfluoresin, and ramipril, right? All are antihypertensives, right? So as we saw, her blood pressure is 130/80 when supine. So maybe her blood pressure was a little bit higher previously. So people kept on adding medications, right? But now when he stands up, blood pressure drops down to 100. So she has postural hypertension. So it might be appropriate prescription some time ago, but now it seems like it's causing trouble. Okay, so as you said, all the antihypertensives can cause postural hypertension, but there are some antihypertensive classes which can cause postural hypertension more than the other. For example, alpha blockers, right, are known to cause postural hypertension more than the others. Diuretics are known to cause postural hypertension more than others. So as you now listed, let me show you the answers. Amlodipine, benfluorethiazide, and ramipril, all are known to cause postural hypertension. All right, and don't forget about amitriptyline. So it's a very deep, very harmful drug in literally in some most aspects. So it has this alpha adrenergic blockade activity which can cause postural hypertension. All right, so I'm going to introduce you another concept here, so which is called synergism. Right. So synergism means when you prescribe more than one medication which has the same kind of effect, they multiply their effects rather than they add their effects. For example, now as you can see in the image, 1 plus 1 is 3. So their effect is more than the desirable effect. So this is called synergism. So combination of antihypertensives. So if ACI drops your blood pressure by 5 and 5 millimeter mercury, and calcium dialbucca reduce your blood pressure by 3 millimeter mercury. So when you add those two, sometimes the effects are multiplying rather than they're adding. Okay, so especially in the older patients, right? And for example, now the sedation by opioid, and if you combine with the benzodiazepine, the sedation will be much more pronounced. So if you look at the example, relative risk of peptic ulcer disease, NSAID is 4, steroids is 1.1, but the combination is can go up to 50. All right. So you need to be careful when you combine the medications, right? The relative risk of bleeding with warfarin is 3.3, NSAID is 2, but combination can go up to 12.7. So this is called synergism. All right. Okay. And now we discuss now this patient is on 3 antihypertensives, right? And her blood pressure supine is 130/80. And as you know, like when somebody is having diabetes, they are trying to keep blood pressure less than 130/80, especially when they are younger. But things can change actually. When you are older and frail, you have to keep less stringent blood pressure targets. All right. So most of these cardiovascular trials, they have excluded older frail individuals. Okay, and if you look at the trials, so for the elderly patients, still the, the good old trial, the high weight trial, is the trial which we are referring most of the time, where they kept blood pressure 150/80, right? All the participants of more than 8 years, I must say, they kept a blood pressure of 150/80 and showed some benefit of blood pressure control less than 150/80 rather than the strict blood pressure target of 130/80, right? And most of the current guidelines, they recommend to reduce the antihypertensive if blood pressure is, for example, now the European guidelines say if blood pressure is less than 120, consider deprescribing antihypertensives. All right. Now the stop trail tool, they recommend to keep systolic blood pressure 138, 160. All right. So especially if someone is having postural hypertension, if they have a risk of falling and fracture, right? You need to balance the cardiovascular risk versus the falls risk. Okay. So I think for this patient, I would give a less stringent blood pressure target. So there's enough room in this patient for the deprescription. And interestingly, if you look at the next slide, right? So this trial, the optimized trial, which was recently published actually, it shows now this was again done in older patients who are on multiple antihypertensive medications. And interestingly, when you take away one antihypertensive medication, when you deprescribe one antihypertensive medication and monitor blood pressure for 12 weeks, there was no significant change in blood pressure. So most of these patients, I mean, let alone high blood pressure causing cardiovascular disease versus falls, deprescribing an antihypertensive might not cause much blood pressure change as well. So sometimes we keep on adding blood pressure medication and the side effect profile goes up, but there's no clinical benefit. All right. So there are a lot of growing evidence about deprescribing antihypertensives in older people, especially if they are frail. Okay. Right. Okay. I think we are clear about it. Do you have any questions? So she was on 4 drugs which can cause this postural hypertension. We discussed about synergism. We discussed about deprescription of antihypertensives. Right. We'll discuss this further in next slides. Okay. Right. Okay. Now this ladies like complaining of constipation. Looking at the drug chart again, can you identify drugs which can cause constipation? So constipation can be multifactorial, like uh, dehydration, immobility, everything can cause constipation, but we're just focusing on excellent. So people have noticed Panadine, calcium channel blockers, they can cause constipation. Excellent. Excellent. Good. Right. Okay. Let's look at the answers. Right. Panadine, excellent. Because of the codeine component, it's a mild opioid which can cause constipation. Amitriptyline again. Yes. So as I said, amitriptyline is harmful in many ways. So it can cause postural hypertension. It can also cause constipation because it's anticholinergic. So as you have highlighted, amlodipine and also sulfenazine because it's anticholinergic. So let's discuss about another concept called prescription cascades. Now, if you go through the drug chart, the patient is on many drugs which can cause constipation, and she is on lactivulose to counteract that. So that's fine. Sometimes we have to use medications to treat side effects, but this can go unnoticed sometimes. For example, the meaning of prescription cascade is you give a drug 1, which gives you a side effect. You don't recognize the side effect as a side effect, but you recognize it as a new symptom. So you treat this symptom with drug 2, right? And sometimes this goes on, and it results in a lot of adverse effects. Hope you are clear about it. You give a drug, and you develop a side effect. You treat the side effect with another drug, thinking it's a new symptom, and then it results in another side effect. For example, now this patient, as we discussed, on 4 drugs which can cause constipation, and she's on laxatives. Sometimes we can't avoid it, but you have to be aware. Now, now this could be a restriction cascade in this patient. Amlodipine causing leg edema. You give benfluoreazide for leg edema, and the diuretic causes urinary retention, urinary incontinence, and you give sulfenazine to treat urinary incontinence. Right? Could be a prescription cascade. So if you look at the other prescription cascades, so this is another prescription cascade. So sometimes you give NSAIDs for leg pain. NSAIDs can cause heartburn and leg edema. and you give PPI diuretic, both can cause hypomagnesemia. Diuretic causes orthostatic hypertension, muscle weakness. Finally, it results in falls. Clear? Right. So more prescription cascades. So arthritis, NSAIDs, high blood pressure medications. So tricyclic antidepressants for depression, which cause constipation. So as we discussed, laxative. Antipsychotics, extrapyramidal symptoms, and give Parkinson meds. All right. So these kind of uh, prescription cascades can go unnoticed. Right. So we have a question. When we prescribe a patient, so question is, when we prescribe a patient on multiple antihypertensive drugs, how do we decide which drug to prescribe? Excellent question. Which order? Excellent question. So it depends actually on what are the adverse effects a patient is having. For example, now if patient is having postural hypertension as this patient, so if the patient is on a alpha blocker, I might first reduce the alpha blocker. All right. And if patient is having, like ankle edema, constipation, those kind of side effects, I mean, next you can think about calcium channel blocker. There are several opinion on AC inhibitors. So some geriatricians deprescribe AC inhibitors a lot, thinking it causes postural hypertension. But even in European guidelines, so there are like some people say it's not that harmful. So if patient is still having postural hypertension after deprescribing alpha blockers and diuretics, then we will go for AC inhibitors. All right. So and sometimes depending on other indications, like if patient is having bradycardia, you will stop beta blocker. But if patient is having ischemic carditis, you will keep the beta blocker as the last resort. Keep it until I mean, deprescribe everything and keep the beta blocker. Likewise, so alpha blockers and centrally acting antihypertensives are the first to stop. Then consider diuretics. And then depending on the patient profile and patient symptoms, consider deprescribing other antihypertensives. That's how it should be done. Good question. Right. Okay. Next is right. So now we discussed about postural giddiness. We discussed about this constipation. Now, what drugs can cause confusion? Again, you have the drug list. Think about it. So I told now this patient had acute delirium following the UTI. She was discharged home and still at home she is having some confusion. So could it be due to drugs? Or I mean, most of these problems you have to remember are multifactorial. Geriatric problems are usually not due to a single problem. These are due to multiple problems. So we have some answers. Excellent. Right. So amitriptyline, solifenacine, panadine. Very good. Amitriptyline. Excellent. Good. Right. Okay. Good. Right. Let's see the answers. Amitriptyline, solifenacine, panadine. Excellent. So you got it all. So what is common about these drugs? So amitriptyline, solifenacine, both are anticholinergics. All right. Panadine has codeine component, which has some anticholinergic effect, and it's also sedative. Okay, so this can affect your cognition. All right. So we don't expect. I mean, if you could remember all the mechanisms of action, that's absolutely fantastic. But if you cannot, just try to remember what drugs has anticholinergic. It is so important in when you prescribe for all the patients, right? So we discuss another interesting entity called anticholinergic burden. Okay, so you might you might not remember what are the anticholinergic effects of the body, but you, so you might have seen these complaints in older people complaining about dry mouth, constipation, memory impairment, urinary retention, arrhythmias. Okay, so these are anticholinergic effects, right? So there are so many people complaining of dry mouth and constipation, right? And so mostly these are due to drugs, okay? And the bad thing about anticholinergic side effects are they are accumulating, right? If you give one anticholinergic drug and give you another anticholinergic drug, these effects are accumulating, and then they can result in anticholinergic side effects, okay? So we need to always consider deprescribing anticholinergics in older people if it is appropriate, right? Okay. And I have this calculator to show. So this calculator called ACB calculator, right? So if you are not quite sure about how to identify drugs uh, which cause anticholinergic side effects, you just go to this calculator called ACB calculator, and then I'll show you a screenshot of ACB calculator. This is ACB calculator. If you click that link, you will go to this calculator. Then you can type the medication list, and then they will give you a score to indicate how much anticholinergic effect that drug has. For example, in this patient, Mrs. Pereira, she was on sulfenazine. It gives a anticholinergic burden of 3. So amitriptyline, it gives anticholinergic burden of again 3. Codeine gives anticholinergic effect of 1. Now the total effect is 7. All right, and when you have total effect of 7, we are expecting a lot of anticholinergic side effects. All right, including confusion. All right, hope you are clear about it. Right. Now, not to forget about this slide. So, as I told you, one of the main problems in geriatrics is falls, right? You might have seen in your practice people presenting with falls. So when you can't find sometimes uh, any major risk factor, look at the drug chart, okay? So there are so many drugs which can cause falls. So these are called falls risk increase in drugs of RIDs. Okay. So as I said, alpha blockers, they can increase falls risks by many mechanisms, especially postural hypertension. Okay. The anticholinergics, antidepressants. So anticholinergics we discussed just a while ago. Antidepressants, they can cause postural hypertension, hyponatremia, sedation, and it increases false risk. Then anti-epileptics, antihistamines can cause sedation. Antipsychotics can cause Parkinsonism, sedation, and a lot of other problems. And diuretics, centrally acting antihypertensives, and then diuretics, opioids, then drugs which we use for overactive bladder like sulfenazine, tolterodine, oxybutynin, which can cause anticholinergic side effects again. And vasodilators in cardiac disease. Those are the main classes of drugs that can cause falls. Okay, so try to screen the medication chart and deprescribe if appropriate. Right. Right. Now we again coming to the same drug chart. Okay. And so what do you think? We now think about the drug chart, think about the all what we have discussed, and think which drugs can be stopped. So we have a question. What is the cutoff level in the anticholinergic burden score? Great question. So there's no such cutoff value, but more the value is, you should know that more the risk of developing anticholinergic symptoms, right? So even if a person is on, let's say, 80-year-old patient with mild cognitive impairment is having uh, bilateral knee joint pain, right? Even one anticholinergic drug, I will be very careful to prescribe. I will not give them amitriptyline, all right? If they are having overactive bladder, I'll be very careful in prescribing a bladder relaxing agent, right? Sometimes we have to do, but we need to screen for worsening of confusion, right? I will be going with conservative methods first, like bladder retraining, the liquid exercises and review, rather than straight away starting a anticholinergic drug because it can cause confusion. Likewise, this anticholinergic burden score is just to get you an idea to see how bad this is. All right, excellent. Okay. All right, excellent. So we have an answer for, medication deprescription. So thiazide, amitriptyline, sulfenazine, glyphosate, phenolate, excellent. I must say. So all these drugs can cause problems, right? So we can consider deprescription, but you can't sometimes stop everything at once. Okay, everything at once. So you have to follow up this patient, and you have to consider deprescription. So if you find it difficult, so I mean, so this is a very difficult business to cut off the drugs. I mean, which are the commonly used drugs. You can use these tools. I'll show you some tools which you can use. Right. So these are very useful tools to consider uh, deprescription, right? So all these tools are made up for geriatric patients on multiple medications to guide you on how to prescribe and how to deprescribe. Okay, so start criteria, quota fit for the age criteria, stop frail criteria, stop fall, Scottish Polypharmacy guideline, and BS criteria. So all these criteria, very nice and helpful criteria. So you can go through these links and hopefully then they can be very helpful. Okay, this slide I got from Scottish Polypharmacy guideline, right? And I like this slide very much. So the Scottish Polypharmacy guideline is very good for deprescription, right? And what I like about this slide is center of deprescription is what matters to the patient, all right? So you have to consider whether medicine is effective, whether medicine is harmful, whether medicine is cost effective, right? And after considering everything, you have to discuss with the patient and see whether the patient agrees about the medication plan, and you have to give right medicine and cut off the unnecessary medication. But center of all is what matters to the patient. For example, we are giving this patient multiple antihypertensives to keep the blood pressure 130/80, trying to prevent a cardiovascular death in 5 years. All right. But patient doesn't want that. Patient wants to walk without feeling giddy, right? She wants to go to toilet without feeling giddy. That's what she wants, right? So we have to discuss with the patient and see what matters to the patient, right? If he can't walk, I mean, we can't, it doesn't make any sense to prevent a cardiovascular death in 5 years, right? Okay. So you have to consider always what matters to the patient, right? So discussing about the effectiveness of drug, I also want to highlight about these concepts of number needed to treat, all right? So the number needed to treat is the average number of patients who need to be treated to prevent one additional bad outcome. So sometimes these numbers can be surprisingly high. For example, now prescribing statins for low cardiovascular mortality, I mean patients having low cardiovascular mortality risk, you have to give 217 patients statin, right, to prevent a mortality uh, with myocardial infarction after 10 years, all right? And then for stroke, it can be up to 313 patients. But if you give for that duration, 10 years of statin for patients with low cardiovascular mortality risk, 21 can get, I mean, if you give 21, one can get symptoms of muscle pain, all right? And then, I can't see that. 200, yeah, if you give 204 patients, one can develop, yeah, so you can read these slides. So there are benefits in NNT and harms in NNT, right? Okay. So there's another concept called time to benefit. So like number needed to treat, time to benefit is how long you should give the medication to achieve a benefit, right? For example, now bisphosphonate, if you give bisphosphonate 1 year, you can prevent a fracture, all right? So if you encounter a patient with advanced dementia who present to you with a fragility fracture, like a hip fracture, who has prognosis less than 1 year, don't bother to give bisphosphonate, right? Because like time to see a benefit is 1 year, so patient might not live longer, right? So statin, so for primary prevention, if you are giving a statin, so to see a benefit, you should give it for 2.5 years. Otherwise, you will not see a benefit, right? Okay, so if patient prognosis is less than that, don't consider statin for primary prevention. All right. So you have to think about number needed to treat and time to benefit. All right. Right. And knowing the evidence is also very important. Now, for example, now this is a very interesting trial which was done in patients more than 70 years. They gave aspirin and so whether it's effective in preventing a cardiovascular mortality. So what do you think is the outcome? So outcome shows if you give aspirin, right, for primary prevention in patients more than 70 years, it's in fact harmful. All right. So it doesn't prevent any adverse cardiovascular event, but it can cause more life-threatening bleeding. All right. So aspirin is not indicated for primary prevention for patients more than 70 years. Okay. Right. And one more slide about frailty and polypharmacy. So I think some of you might be familiar with the concept frailty. For whom that you are not familiar, frailty is a state of vulnerability where elderly patients have their physiological reserves getting low. Okay, so they are more vulnerable to medication changes. So if you give a medication, you have to monitor carefully for side effects. All right, so you have to handle with care. All right, that's why I told this patient should have less stringent blood pressure targets. Right, so blood pressure of 150, 160. Right, sometimes will be uh, will be the target for the frail older patients who are having multiple force and postural hypertension. Right? It's not 130. Okay. Glycemic targets. Now this patient had HbA1c of 5.8, which I told to strict control. Okay. So I would say if you look at the ADA guidelines, they have clearly given uh, HbA1c targets for older frail elderly patients. So for this patient, I would say I am happy with HbA1c of 7.5%. All right. Sometimes you can go up to 8%. All right. If they are very frail, right, having a low life expectancy. Okay. And always review anticholinergic burden in frail older patients. Right. Right. Now, again, back to the same question. So we discussed a lot of principles. Now we're going to see what medications are inappropriate. So we got some answers already, and so there are some question chat box. Right. So the questions are right. So yeah, I'll ask the coordinator to share the links in the chat box about the prescription criteria, prescription tools, and bisphosphonate isn't duration needs 3 years. So I mean, the number needed to treat, sorry, the time to benefit is about 1 year, bisphosphonate, but it's indicated in many guidelines to prescribe for 3 to 6 years in the first go, and 3 to 5 years if it is IV, depending on IV or oral, and then you can extend up to 5 to 10 years. All right. So the time to benefit is usually considered as 1 year. All right. If prognosis is less than 1 year, you don't give bisphosphonates. Right. Okay. These are the answers I thought for this question. Right. So as most of you suggested, we are cutting off now diuretic because she has urinary incontinence, her blood pressure is too low, she is having postural hypertension. And we are deprescribing Panadine because of this codeine causing confusion and constipation. So and someone has already suggested to cut off glycoside. Excellent. So I agree with that. Can cause hypoglycemia and it even is too low. Amitriptyline, we discussed having a lot of anticholinergic problems and worsen postural hypertension. But remember, when you cut amitriptyline, you have to reduce it slower. Okay, so it can cause sometimes withdrawal. So you have to cut it down and wean it off rather than stopping it abruptly. And solifenacine, if you have alternatives, we can take it off, or we can later consider. I mean, after stopping, we don't stop everything together. After stopping some other medication, we review them and consider prescribing solifenacine and see whether they have actually practiced any conservative measures. And then, as I discussed, aspirin is not indicated for primary prevention in this patient. All right, so we can cut it off. And amlodipine versus ramipril depends on your choice actually. Now this patient I selected amlodipine because she has potential prescription cascades where she was having ankle edema and prescribed thiazide, and she's having constipation. And ramipril can be sometimes be good to prevent diabetic nephropathy, and there are new research about sarcopenia versus ACE inhibitors. But if someone thinks it causes postural hypertension, when you follow her up, you can switch back to amlodipine and reduce ramipril. Right. Okay. Now, Miss Pereira is very happy. She is not feeling giddy anymore, so she is ready to fly. And so this is the final prescription: Pramiprile, metformin, and still continuing lactulose, paracetamol. And you have to consider some other non-pharmacological methods like heat therapy, and oil therapy for pain. And you can get local application of diclofenac gel or something, and use conservative methods like liquid exercises, bladder retraining, And then, but it's not always about deprescribing. You have to think about what are the other appropriate medications. So you have to think whether the patient needs calcium and vitamin D, and then this patient is having high risk of fractures according to the FRAC score, and consider a bisphosphonate. And mirabegron is a drug we frequently use in geriatrics, but unfortunately not available in Sri Lanka at the moment. It's a beta-3 agonist where you relax the bladder with a different mechanism. So you don't have to give anticholinergic to relax the bladder. So if we have mirabegron, we can put it in place of solifenacin. Okay. And finally, you have to discuss the drug list with the patient and get into agreement. Okay. And not to forget about pillbox. Okay. Now this patient has problems with compliance. So why not suggest a pillbox? Okay. Right. Just to again revise some important criteria in prescribing drugs in elderly people, start from the low dose and go slow. Right. Don't start the highest dose. Okay. Start very low dose and slowly increase the dose. Okay. Monitor for side effects. Assessment of frailty and renal liver functions is important, and consider non-pharmacological methods, and never start a new drug without considering the current drug can be stopped. Keep the drug list very short and check for adverse drug reactions, synergisms. We have just discussed about that. And avoid high risk medications and drugs with high anticholinergic burden, and simplify drug regimes. And these patients can't remember most of the medications, and the compliance are not the best. And treat the patient and the care as well. All right. So just before winding up, I'm going to discuss a few short cases just to give you this idea of deprescription again. Okay, I will be quick. Case 1. A 90-year-old male presented with a fall at home and fracture of his right neck or femur. So past medical history, hypertension, dementia, ischemic heart disease. She had a stent 2020. Okay. Blood examination, blood pressure is 90/60. These are the investigations. He has low sodium, and vitamin D is quite low as well. Right? So when you see the drug chart, these are the drug chart. So think about what drugs to be stopped, what drugs to be started. I'll show you the first slide again. Short history. These are the drug chart. We have some answers coming. Excellent. So very good. Right. So as you can see, right. Now, this patient is having low blood pressure, 90/60. So I told you, like, if blood pressure is less than 128, you have to consider prescribing in elderly. So 90/60 is pretty low. So stop pramipil. And so the stent was put on 2020, and now he's on dual antiplatelets even after 3 years. So dual antiplatelet duration, usually 1 year, can extend up to 18 months depending on the bleeding and thrombotic risk factors. But now this is after 3 years, it's not indicated. So you stop clopidogrel. And when you give dual antiplatelet, sometimes you consider giving a PPI, which is a good practice to prevent gastric bleeding. But if you deprescribe clopidogrel, you can probably get out of PPI. Okay, proton pump inhibitor. Stop PPI. And this patient, his blood pressure is low. You have to think about getting rid of furosemide. And probably this patient, I think, I mean, most of these patients are they are dry actually. So they are inappropriate on diuretic. So stop furosemide, especially perioperatively. Furosemide can cause AKI. So I would rather stop it. And he has hyponatremia to aggravate the things. And amitriptyline, as I said, we know of amitriptyline. And simvastatin dose, sometimes we have to review and reduce when they are quite frail. And it's not always about stopping. You can start calcium, vitamin D, and if you start antihypertensive because of ischemic heart disease, I would start bisoprolol, which also can prevent the perioperative myocardial infarction and things. And then consider giving either zoledronic acid or denosumab after vitamin D replacement. All right. Second case, 75-year-old male with Parkinson's disease was seen in the outpatient clinic. He has 4 falls in the last month. Wife reports that he is getting confused at time to time and doing more and more Amazon shopping. And this is past medical history, Parkinson's disease, hypertension, urge incontinence, and significant postural hypertension of 140 dropping to 90 systole when standing. Right. So these are the medications. Any thoughts? So I have a question about, is it okay to remove two antihypertensives at once? Very good question. So I would say stop one at a time, okay? But if someone is really hypertensive, like if a patient coming with blood pressure of 100 by 80, right? So we can stop everything basically and then monitor the blood pressure, okay? It depends on the situation, but stopping one at a time is very gentle, and I mean, uh, we should try that first. But if blood pressure is really low, we can stop all antihypertensives. Right. Good question about, have I seen a patient with normal vitamin D? Yes, I have. But just to remind that vitamin D is quite low in many patients, and I think it's clinically uh, correlating, right? So, because like most of these patients, they are not getting enough sunlight, okay? And most of the elderly patients are housebound. And if you do DEXA scans in these patients, which I am doing at the moment, you might see a lot of patients with uh, very low DEXA, right? Bone mineral density, right? So vitamin D really low. I am really worried about it. So replacing vitamin D for patients with vitamin D deficiency quite a lot. Excellent. So we have good answers, right? Excellent. Now this patient is doing Amazon shopping. Why is that? So it's a side effect of robinolol, right? Compulsive shopping. So he has compulsive shopping. So stop propinerol. Quite agree with that. And seems like he's getting confused time to time. So probable cognitive impairment, right? And he has significant postural hypertension. And so stop propinerol. And oxybutynin is kind of very old-fashioned drug for this urinary urgency, but it's non-selective anticholinergic. It's not good for your brain. And so I will rather stop it and consider solifenacine better than oxybutyrin in regard to the confusion. But if you have something like mirabegron, definitely better than both of them. And then consider rivastigmine after cognitive testing, and just syndrome if you reduce roperidol, and then consider fludrocortisone or midodrine for postural hypertension, because the Parkinson patients are more prone to postural hypertension due to Parkinsonism and many reasons. And then osteoporosis treatment again, because this patient is a multiple faults. Right. Now, last case, right? 70-year-old woman was seen in the outpatient clinic, and she is recently started on statins due to mildly raised LDL, right? And triglyceride, and now feeling increasingly tired, has muscle aches. So she was started on statin, now feeling having muscle aches. Quite straightforward, isn't it? But she was started for mild raised LDL and triglyceride, and past medical history, when you see, she has hypothyroidism, total knee replacement, hypertension, URD, iron deficiency anemia, and hyperlipidemia, right? Recently diagnosed. Investigation show high TSH, right, and low T4 and high CK, right? So these are the mitigations. So can you think about the potential problems here? So levothyroxine 75, but still TSH is high. So she's on ferrous sulfate, she's on paracetamol and ibuprofen, right? For knee pain, but she had knee joint replacement, and she's taking omeprazole, Gaviscon, and atorvastatin recently started. Okay, so can you see a lot of prescription interactions and cascades here? Now, NSAIDs can cause peptic ulcer disease. Peptic ulcer disease can cause iron deficiency anemia, right? So, also you have to remember how to take these medications properly. So now, iron affects thyroxine absorption. Ideally, you need to have 4-hour gap between thyroxine and iron, but most of the people are not aware and not doing that properly. So this can affect thyroxine absorption and result in low thyroxine levels. And hypothyroidism cause dyslipidemia and also make them susceptible to statin side effects like leptobarosis. Right? So there are complex prescription cascades. Uh, right. Okay. So you need to stop statin because CK is high anyway, and stop ibuprofen. Now we have to relieve the pain. Maybe patient was put on ibuprofen before she had the knee replacement, and she's taking it. Right? So you have to relieve the pain and stop ibuprofen and keep more than 4 hour gap between iron and levothyroxine. And also antacids has to be kept with levothyroxine, and relieve omeprazole and Gaviscon syrup later after stopping ibuprofen, and start regular paracetamol ibuprofen gel PRA. All right. That's the end of my presentation. So let me check the chat box. There are some messages. Yeah, agree. So question, a lot of questions about vitamin D. If marginally low vitamin D, it's indicated to give vitamin D 1000 for a long time period. So if a older patient is having high risk of fractures and falls, if they are not getting enough sunlight, yes, it's a daily requirement, no harm. So even though the range is like 20 to 50, do you know that if when vitamin D's level is less than 75, the parathyroid hormones start to secrete more, and it's not good for your bones. So it starts bone, reabsorption when level is less than 75, even though it's like less than 50, we are replacing. So you have to have low threshold. So stop blend fertilizer, yeah, excellent. How can we replace vitamin D without vitamin D levels? Yeah, so good question again. So if so this happens a lot actually because doing vitamin D levels quite expensive. For example, if you do vitamin D from outside, it costs 10,000, and if you do it government sector, it's about 3,500. But still, it's expensive. So sometimes if you need to start, if you clinically suspect vitamin D deficiency, you can load vitamin D. I usually give 60,000 weekly for 5 weeks, followed by the daily requirement. And especially if you want to give bisphosphonate, so alendronate, we can start with vitamin D deficiency while replacing vitamin D. It doesn't cause much hypocalcemia. But if you go for further treatment like zoledronic acid or denosumab, you definitely need to have normal vitamin D before giving those drugs because they can cause resistant hypocalcemia. So I usually give replace vitamin D before you zoledronic acid and denosumab. So, but the problem with sometimes if patient presenting with hip fracture in the ward, and they might not stay for weeks before going home, and if you could give zoledronic acid before discharge, that's quite beneficial. So, in those instances, we have this rapid loading regime where we load patients with vitamin D in consecutive 5 days, 60,000 daily for 5 days. We don't practice it in normal patients, but considering uh, everything like this is the cost of hospital stay and everything. Sometimes we give rapid loading of like 60,000 daily for 5 days and then give zoledronic acid before discharge. This is not only Sri Lanka, this is practice elsewhere in the world, even in UK. And we had some regional discussions in Asia about, and they also practice the same thing. So how long it will take muscle days to present after strength steps? So it's quite idiosyncratic. So you don't have exact time. Is it recommended basal bolus insulin in delivery? Yes. An antihistamine post delirium? Yes, definitely antihistamine post delirium is a sedative. Right. Okay. Thank you very much for your participation. And any more questions? Or can we wrap up?
So there are a few questions that were sent before this lecture.
Yeah. Yeah.
Mainly they are on prescribing analgesics in older adults. They
Yeah.
have asked whether it's okay to prescribe NSAIDs for more than 2 weeks in old age patients with back
Yeah.
pain, and also about morphine for pain management.
Right. Okay. So now, so it depends on how the pain is, what type of pain it is, whether it's inflammatory type of pain, whether it's kind of neuropathic pain, malignant pain, what it is. So both NSAIDs and opioids have its place in prescribing in older patients. But said that, they also have side effects. For example, NSAIDs especially are not desirable in elderly patients. They can because they are not drinking enough, so they can have a lot of renal side effects. They can have a lot of GI side effects, right? And if it is kind of pain following a fracture, NSAIDs delayed fracture healing, right? So there are a lot of problems with NSAIDs, but sometimes if there are inflammatory component in the pain, we give short course of NSAIDs, all right? So, and when it comes to morphine, right, I think we are not using morphine to the extent that should be used. I think it's underprescribed at the moment. So, but said that, Don't use morphine inappropriately in patients. It can cause sedation, confusion, and very bad constipation. Okay, so then when you prescribe opioids, you have to give sometimes concurrent laxatives. All right, so all the analgesics have its place, but you have to carefully analyze the pain before giving any analgesic.
So there's one more question. Do older adults need dose reductions in commonly used drugs when they are otherwise healthy? For example, antibiotics and other commonly used drugs?
Usually antibiotics, no. So, but you have always refer to the ENF and see whether it's kind of a weight calculated dose you have to give. So if so, then you have to have patient's body weight and then calculate the dose. Otherwise, no. And most of the other medications, so you have to start low and go slow. That's the principle. Okay. So if patient is very frail, start from low dose and then titrate, review, and then if they are tolerating it, then increase it. All right. Don't start high doses at once. That can sometimes cause side effects and patient might not continue the drug. Right. So start low, go slow. That's the principle.
That's all for the questions, sir. We
Great.
sincerely thank you for your valuable time, and this is a very excellent, timely, and a informative lecture. I think it is important for all the medical officers who are in clinic setups and OPDs. Thank you for your time to educate us.
Yeah, you're welcome. Thank you very much.
There is a link in the chat box for the e-certificate. Kindly give your feedback and answer the post-assessment questions and receive your e-certificate for participation. It will be sent to you within this week. We are winding up this session for this week. We ask you to join us next Sunday morning for another lecture like this. Thank you very much.
Thank you.